Miliary tuberculosis in a QuantiFERON indeterminate patient on infliximab therapy. Miliary tuberculosis results from massive hematogenous dissemination of tuberculosis typically to the lung, bone, and less commonly to the gastrointestinal tract. It accounts for 2% of cases and can present as life-threatening septic shock in the setting of immunosuppression and immunomodulatory and biologic therapy. A 53-year-old Cuban male physician with moderate to severe ileocolic Crohn's disease and a travel history to Cuba was recently initiated on infliximab due to the failure of conventional therapy. His pre-treatment interferon gamma release assay as well as tuberculin skin tests were negative. After completing 14 weeks of treatment, he presented with a 10-day history of fever, nausea, and emesis. He also recalled unintentional, undocumented weight loss over his treatment course. Colonoscopy with biopsy revealed severely inflamed mucosa at the ascending colon extending to the cecum, and findings suggestive of granulomatous disease. With the diagnosis of a presumed Crohn's disease flare, the infliximab dose was appropriately doubled and steroids were given. Biopsies subsequently revealed numerous acid-fast bacilli. The therapy was immediately aborted and the patient was advised to initiate tuberculosis treatment. He returned 8 days later with generalized weakness, an additional 20-pound weight loss, and a rapid decline to septic shock and multi-organ failure. During emergent exploratory laparotomy, the small bowel and omentum were studied with a white granulomatous nodules. He expired on the first post-op day. Samples, sputum, omentum, and abdominal wall cultures were all positive for Mycobacterium tuberculosis. Repeat ergo testing was indeterminate. Now, Crohn's disease is a chronic granulomatous inflammation and destructive disease which follows a relapsing and remitting course. Infliximab therapy is initiated in moderate to severe stages. However, it carries with it an increased risk of reactivation of latent TB. Interferon gamma release assay testing before and during treatment is important, especially in the setting of clinical deterioration while on infliximab therapy. It is difficult to surmise whether the subsequent hospital visits after the initiation of infliximab was due to worsening Crohn's disease or manifestation of intestinal TB. Chronic granulomatous disorders of the intestine have a strikingly similar features in presentation, making it challenging to distinguish one from the other based on symptomatology alone. The patient's insidious weight loss and rapid decline, concomitant with escalation of infliximab and corticosteroid use, points towards intestinal TB as the cause of his symptoms. Now, despite a high sensitivity of interferon gamma release assay, this patient's travel history to an endemic area decreases the negative predictive value of the test. Diagnosis of miliary TB is challenging given its non-specific presentation and limited diagnostic modalities. Therefore, patients who are continually exposed to endemic areas or continued on immunosuppressive therapy should prompt frequent diagnostic reevaluation prior to escalation of infliximab dose.